a risk you'll have to take. Anyway, if you wanted to find out how the brain worked, what the brain did, how could we go about doing that? Anybody got? Yes. You could cut the brain open and look at it. Okay, that's option 0 on my list of 1 to 4. No, it's not because it's trivial in any sense, but I'm looking for techniques that get more at the function than at the structure. But there is a certain amount that you do learn from just looking at the structure. In fact, Descartes, one of the founders of the dualist view, looked at the anatomy of the brain, thought, if the immaterial mind and soul are interacting with the brain, well, the brain is a doubled structure, right? It's got these 2 sort of symmetrical hemispheres. That interaction between the immaterial soul and the body must be at one point. He looked at the anatomy, saw the pineal gland, which is a piece of brain lying on the midline, and thought, because there's only one of those, that must be the point. So you can make inferences from structure alone. That particular inference is wrong, but you could do it. Yes, the person in front there. Yes, you. You're okay, MRI, we will make that into the larger category of imaging techniques. For psych purposes, the most dramatic version of this is so-called fMRI, for functional magnetic resonance imaging. This is the new entry on the list, really. Remarkable breakthrough in the time that I've been teaching this course is the ability to now look at the structure and some aspects of the function of the brain in intact, alive, awake human beings. You simply couldn't do that anymore, and that's a remarkable, it's a remarkable boon for psychology and a huge advance for medicine. So, for instance, if you had a brain tumor, there are symptoms of having a brain tumor, but the only way to find out if you actually had a tumor, because you'd want to take this tumor out if you could, the only way to find out a generation ago was to do exploratory surgery and open up the brain and see where the thing was. Now you'd be in an MR scanner by the end of the day, and we'd know. So, yes, very useful technique. You're going to offer me another one?
Yeah, you can study people that have had brain deformities and have been in accidents and things like that.
Okay, so we'll put this under the category of lesions, brain damage. If this is the newest, this is probably the oldest of the basic techniques. If you damage brains in the same way, you end up getting symptoms that are similar across people and even across species in many cases. And that is a tip-off that, first of all, that the brain has something to do with mental life, and that specific bits of brain have specific things to do with specific aspects of mental life. The real advances in this sort of research and this sort of understanding of the brain came, I guess, mid to late 19th century, when, with advances both in medicine and in, I suppose, what you could call military technology. In earlier times, if you got a penetrating wound to the brain, odds were that you were simply going to be dead. But by the mid to late 19th century, people were surviving with penetrating brain injuries, and it became clear. And bullets could be leaving comparatively small lesions. And so it became increasingly clear that different bits of brain damage did different things. Let me find myself a place to draw another picture here. I need a brain. So here we go. One quick. This is your brain. Just to orient things here. Okay, so front, back, bottom, top. If I'm facing that way, this would be looking at the outside surface of the left hemisphere. There, right? You got two cerebral hemispheres about this size stuck inside your head. This is the brain's got lots of wrinkles. There are a couple of large ones that I'm drawing here for my purposes because the cerebral hemispheres are conventionally divided up into 4 lobes. The terms for which are written on the handout, so I can just give you the initials rather than writing out the whole thing. Conveniently, the frontal lobe is at the front. After that, you just simply have to learn them. Temporal lobe down at the bottom, occipital lobe at the back, and the parietal lobe on the other side of this big central sulcus that divides the frontal from the parietal lobe. What was found, I think originally in the Franco-Prussian War, if memory serves, 1870s, was that if you got, lesions to the back of the brain here, to the cortex, so the wrinkled outside surface is known as cortex. That's from the Latin word for cork, which is what anatomists thought it looked like. If you get lesions back here, you get problems with your vision, very specifically. And if you got a great big lesion that took out the entire occipital cortex on both sides, you'd be functionally blind. But if you got a small lesion, let's say in the left hemisphere, you would have a small region of blindness, and it would always be on the right side of the visual world. And that's relative to where you're actually fixating at the moment. So if I fixate on this guy there who I'm now staring at, then if I had a lesion in my left hemisphere, some region out here, I would be blind. If the lesion was in my right hemisphere, the blind region would be on the opposite side, on the left. That's the sort of thing that you could discover from lesion studies. And so lesions happen when you get brain injury from, say, a bullet. Lesions happen from strokes. One of the great advantages to imaging technologies is that in the 1870s, or even until quite recently, the only way you knew about where the lesion exactly was if the patient died and came to autopsy. You could look at the brain and look what was damaged. Now you can look at that brain in an intact individual and see where the damage might be. So damage to the brain can tell you something about it. It's got the drawback that you're trying to infer normal function from an abnormal brain at that point, and that's not perfectly straightforward. But it does provide, and is perhaps the oldest technique for providing lots of information. Yes, are you about to give me another method? Behavior. Okay, behavior is item. Well, if that's 0, then behavior is going to be 5. And we'll spend an awful lot of the course talking about behavioral measures. But in behavior, without going in and doing something with the tissue of the brain, you're essentially treating the brain as a black box at that point. It may tell you something about the brain in connection with the rest of this, but we're looking for techniques that are specifically about studying brain itself. Yes? Wake surgery. Oh, this sounds cool. Yeah. Keep going. What did you have in? They pretty much experiment simulating different centers of the brain. What's the surgery part? I can fill it. I'm just trying to see if there's a 6 here that I'm just not thinking of that would be cool. Otherwise, I can sort of. We've done some experimentation in the lab, trying to see how different substances affect brain activity. Oh yeah, actually that's one I didn't put in typically, which is that you can go in and start infusing stuff into chemicals into the brain and changing behavior. Do I want to say anything more about that at the moment? Good. I'll use that one. Thank you. We'll call this stimulation in general. Stimulation. You can go in and stimulate brain. So I was gonna do that and segue from the chemical stimulation to electrical stimulation, but you got there for me. You can go in and stimulate the brain electrically in rats, but you can also do this in humans. In fact, back in the 1950s, Wilder Penfield, psychologist, was working with some neurosurgeons up in Montreal, and what they were doing was they were doing neurosurgery on patients with intractable epilepsy. Epilepsy is an electrical storm in the brain, basically, and often is started by a piece of abnormal or damaged tissue that acts as a generator. And then what happens is a sort of an abnormal electrical activity spreads from that point of generation across the brain or across some chunk of the brain and causes a seizure or lapse of awareness, the sort of symptoms that you get in epilepsy. Often this is controllable by drugs, but in some cases it's not. And one of the treatments that can be tried is to go in and try to lesion this little chunk of brain. If you take out the generator, you can often reduce the severity or eliminate the seizures. But if you're going to take brain tissue out, you got to be really careful, because, well, actually, where I put this is a pretty good example. We knew from lesion studies, going back again into the 19th century, that areas around here that go by names like Broca and Wernicke's area, which are the names of 19th century neurologists, actually, vitally important in the production and understanding of language. If you are right-handed, those areas exist in the left hemisphere of the brain, so this is a left hemisphere of the brain, that'll work fine. And if they're damaged by stroke, you will have trouble with understanding language or producing language, or both, depends on the exact nature of the stroke. But very bad lesions to have. So if you were to discover that the epileptogenic focus, the piece of bad tissue, was sitting in there, you would say, look, I'm sorry, we don't want to do this surgery, because while I could perhaps reduce the frequency of your seizures, it's going to mean that you've got real problems with language, and that trade-off is not worth it. On the other hand, if the generator was here, say, look, I can reduce the frequency of your seizures, and you'll have a relatively small area of blindness out in the right visual field somewhere. Say, look, I'm not thrilled about being blind in some part of my visual field, but that trade-off is worth it. So you need to know where you are in the brain in order to do this sort of surgery. And what Penfield did was to stimulate the brain of awake individuals, in effect to ask, what's this bit of brain doing? Now, how can you do that? Doesn't that kind of hurt a lot? The answer is that they're under local anesthetic to get through the skull and the outer surface, the membranes across the surface of the brain, because in case you hadn't noticed, digging holes with a sharp stick in your skull really hurts. But once you get to brain, there are no pain receptors in the brain itself. There's nothing. Once you've got the brain exposed,